Hello, good evening. Thank you for joining us tonight for our session on COVID-19 management in primary care, preparing for the new business as usual in the Hunter, New England region. My name is Charles Broadfoot and I'm one of the professional development officers with Hunter, New England Central Coast Primary Health Network. I'd like to begin by acknowledging the First Peoples and traditional custodians of all the lands in which we are meeting on tonight, pay my respects to elders past, present and emerging, and also welcome any Aboriginal people who may be joining us online. Tonight's session is being recorded and the recording and the PowerPoint slides will become available from tomorrow in our education library on our website. So to access these, you just head to our homepage, thepHN.com.au, and click on the Education tab. We will be using Slido tonight for your questions and also the session evaluation survey. So you can access the Slido polls and Q&A tabs on the right-hand side of your screen if you're watching from a computer or laptop. Or alternatively, you can head to slido.com, so that's SLIDO, and enter our event code for this evening, which is CMPC. So that stands for COVID Management Primary Care. Or a third option is by scanning that QR code that you see has popped up in the corner of your screen. So please type your questions tonight throughout at any stage throughout the presentations. Please know we have allocated time after the presentations for a panel discussion. So I'll now hand over to John Bailey, who is an Executive Manager with the PHN. John will introduce tonight's speakers and our panelists, and he will commence the first presentation. Thanks again for joining us, and I'll hand over to you, John.
Thanks, Charles, and welcome everyone. Thank you for joining us for this education session. As we reach target vaccination rates here in the Hunter and across New South Wales, it's clear that we'll be opening up, and there is a risk and an opportunity that there will be more COVID-19 people, positive people in our community. This will require primary care, including general practice, to be able to manage those people safely and effectively. Tonight, we've got a range of speakers who will provide you with their insights and their experience in developing pathways and other care tools to assist in the management of COVID positive patients in the community. We've got Tony Merritt. Tony is a public health physician with Hunter New England Public Health Unit. Dr. Marie Puxty, who is a GP at West Armidale Medical Centre. Dr. Miriam Grotowski, a GP at Smith Street Medical, Tamworth. Dr. Joanne Wood, who's a GP here in the Hunter and works at the Belmont COVID-19 Vaccination Centre. Dr. Michelle Redford, who's a GP here in the Hunter, works at Black Buck Doctors and with the PHN. Dr. Letitia Wills, who's a GP at Waratah General Practice. And we welcome you to tonight's session to get a better understanding of the preparation and work that's been done. What I'd like to do is just give you a bit of an overview of what is being done at the Commonwealth level in terms of preparing for what the Commonwealth call living with COVID. The Commonwealth have recently advised that there will be a new Medicare MBS item number that can be billed for face-to-face sessions. That item number is a 93715. The number can only be used with face-to-face MBS item numbers and can't be used with telehealth item numbers. The Commonwealth are also working through the triage and prioritisation of patients with the jurisdictions, including New South Wales Health. There'll be further work done on that over the coming weeks. This evening, we've released an EOI to general practices in our region to be able to express an interest in participating in care of COVID positive people in the community. I urge you to have a look at that EOI and provide a response to the EOI if appropriate. What I'd like to do now is hand over to Dr. Tony Merritt to talk through the current status in HNE and the New England response. Thanks, Tony.
Wonderful. John, thank you very much for the introduction, and lovely to be with everybody. It feels like a fairly long time since I joined you on a PHN presentation, so great to be here. Got some slides, and we'll just see if this brings it up. Fantastic. So, look, I got nostalgic preparing for this and fished out a slide that you can see the date there, 14th of February last year. So, several dozen COVID years ago. Remember back when COVID was just starting? It was 60,000 cases internationally. Australia didn't make it onto the leaderboard there. I haven't looked at this site for probably 12 months, but that's it earlier this morning. 250 million cases counted worldwide, 5 million deaths. So it's been an extraordinary and torrid time for lots of us, but very grounding, I think, to just keep in mind what's happening on an international perspective. I've just got a short presentation tonight. I just want to give a little bit of a feel for the epi situation here in Hunter, New England, perhaps delve into a couple of the issues which I know are topical. There's the epi curve just for this third wave, the Delta wave in Hunter, New England, just Hunter, New England cases. So from mid-July, and that's the activity over the last 4 months. And so particularly this last couple of months, really sustained case counts, you'll all be very much aware of, but staying stubbornly 40 to 80 on a couple of occasions, over 100 cases a day, to the extent that we are top of the charts for districts around New South Wales, often accounting for a third or more of cases in the last couple of weeks. So it's been an intense time, and COVID, particularly this Delta strain, has really picked out vulnerable communities, and that'll be a theme, I'm sure, tonight. Just over 3,500 cases in the period we're talking about. Extraordinarily, 31% of those cases Aboriginal. So, particularly this last month, the cases amongst Aboriginal populations have been a real feature of COVID. Hospitalisation rate in this wave certainly lower than last year, 7%, and we'll have a look at one of the reasons for that in a moment. Just under 1% of all people ending up with an ICU admissions, and 14 deaths over that period of time. Still in Australia overall, the mortality rate for notified cases is around the 1% mark. And again, that's strikingly different there, our experience this wave than last year. And we'll see why in just a moment. Just in case you're interested in a little more detail on the percentage of your patients ending up in hospital with COVID, just focus on that right-hand column. That's the percent admitted to hospital. And as you'd expect, older patients, once you get up over 60 years of age, a proportion in the round, a third or more being admitted to hospital. But we've seen some admissions right across the age spectrum. And part of the story there is this absolutely striking pattern of the age profile of COVID cases in this wave. This is dramatically different to the sort of demographics we were looking at together last year, and it's just testament to the profound impact that vaccination has had on protecting the older age groups there. So these are case counts for this latest wave, and just striking level of activity in children and young adults. So clearly an under or unimmunised population, so particularly children and their parents. And that plays out, of course, in amongst our families and amongst your patients in so many ways, and striking number of cases both in schools and in early learning centres, having real impacts for us all in that regard. COVID's been active throughout the region. We've got great representation from across Hunter, New England tonight. So we're familiar with extensive activity in Newcastle and Lake Macquarie. So the numbers on the left there are total cases in this third wave. Lots of activity up in Port Stephens, Maitland, Cessnock. And then the story of the last couple of weeks in particular has been up in the New England area. So that chart on that image on the right captures a sense of Aboriginal cases, and the darker being increased numbers. And you can see the impact of the current outbreak in Moree, top left there. Currently over 140 cases in the Moree district. Only started Monday last week. 98% of those cases identify as Aboriginal. And lots of case activity, particularly amongst Aboriginal people in both Tamworth and now Inverell, Tingha. And we expect that's going to be a real pattern over the months ahead, and see COVID spread into areas that are not currently impacted, as shown on that chart. Mentioned vaccination, and sorry, that's a busy slide. The column on the right, this is from just earlier in the week, column on the right is 2 days coverage by local government area in Hunter, New England. And it's just extraordinary to be celebrating over 90%, 95% vaccination coverage in some of those LGAs. This is in those aged 16 years and older. I think very few of us would have thought that was possible 2 years ago. And so just an extraordinary success story. So congratulations to all of you who've worked so hard to make that happen. There's a backstory, of course, behind that. Those just extraordinary figures hide differences and under vaccinated groups in the community, and there's an up to 20% gap amongst Aboriginal peoples, particularly up in the New England area. So lots of effort going into that as we speak, and there's still lots of work to do there. I point to, obviously, there's still the issue of younger folk under the age of 16. There'll be more on that, no doubt, in the months ahead. And I'll just flag that for those people who are waiting for a second dose of AstraZeneca vaccine, that there's definitely the live option of shortening the interval between doses in the kind of circumstances we find ourselves in now, with widespread community transmission in those areas, to as short as 4 weeks. And in this outbreak setting, then an interval between doses for AstraZeneca of 4 to 8 weeks is the ATAGI recommendation. I thought I'd just give a very brief update on how the contact tracing processes have evolved. And this has been extraordinarily dynamic, and it overlaps with many of our interests. In terms of case notification, of course, that's still coming from laboratories. I must say, some of the labs do let patients know before us, so that's an awkward situation. I know it is for yourselves, as it is for us when patients find and are calling before we've had a chance to call them. But overwhelmingly, once there is a laboratory notification, we're getting to case interviews inside 24 hours. And the process for that is very standardized across the state. It's an online questionnaire. We're managing to do most of our own interviews locally at this stage, but at the busiest times, the ministry or other local health districts have been helping. So people may be interviewed by people who are out of our district. And then there's a uniform passing over of all COVID cases to the COVID care and the home teams, the adult and paediatric teams. And as a rule, we have very limited ongoing role with cases beyond that time. Close contact management has changed really dramatically over the last 6 months. It was a huge part of the workload for us, where we would telephone every close contact. And for some cases, you can imagine that might be 20 or more people. The process has been streamlined for pragmatic reasons, and so every close contact in New South Wales receives a standard formal New South Wales Health SMS. In Hunter, New England, we're not calling any close contacts ourselves, but most will still get a phone call, a single phone call from the contact tracing team at the Ministry of Health. So there's much less oversight by us about the information that flows to close contacts. And we're relying on people having the correct information and interpreting it. So that's a substantial change. Also a big change to venues and exposure sites. So again, a couple of months ago, pretty much every site that a person went into when they're infectious would be listed on the New South Wales Health website and be subject to some review by us. And there's been a very much a focused effort on high-risk settings. So we're still very interested, get very engaged in settings such as general practice exposures, aged care, workplaces with high risk of transmission. But some settings will no longer trigger risk assessment. So, for example, retail settings, supermarkets, and so forth. The listing of sites on the New South Wales Health website is being phased out very much at the moment. So I think within 2 weeks or so, there'll be very little listed at the New South Wales level. We're still listing key sites, really sites of particular concern locally, particularly on the Hunter New England Facebook site. And there's this progressive move. I know many of you have had alerts on your own Service New South Wales app. That's something that's being progressively refined, but there will be a reliance for other venues, for example, supermarkets and so forth, where someone has been infectious, to get an automated message through the Service New South Wales app. And we can talk about that more later on if that's helpful. So that's the contact tracing process, really significant changes there. The other area where there's been, I'll just wait for that slide to change. Bear with me. Great. There's been a lot of change in terms of management of cases and close contacts. If you've got fact sheets that are any more than like seriously a week or so old, I seriously recommend that you always check for the latest version. They've changed a lot just in the last week or two, taking into account progressively the benefits of vaccination in terms of impacts for people who are close contacts in particular. So I think we're the advice for people who are cases and close contacts and have capacity to isolate on their own, that's pretty straightforward. It's nicely set out in those fact sheets. But for lots of families, the real challenges come particularly with the number of cases in school-age children, in early learning centre-age children, where large numbers of close contacts are needing to isolate at home and can't be separate from their families. At least one parent needs to isolate with them. If you haven't seen it, I strongly recommend this fact sheet as something very helpful for navigating that process. If you Google that, frequently asked questions for parents and carers of people who need to isolate due to COVID-19. And I've just extracted on this slide and the next a couple of the key messages. So for example, somebody, a parent who is isolating together with a child who's a close contact from school, the child's the close contact, the parent is not. So if the parent is not fully vaccinated, they need to self-isolate with that child for the full isolation period. For a fully vaccinated parent, no need to isolate, but that parent is restricted from high-risk settings, such as coming to work in a healthcare setting. And we'll just move on to the other really frequent scenario. Again, this fact sheet's, I think the application to close contacts who can isolate is relatively straightforward. But if you're the parent with a child who's a case, then even if you're vaccinated, you need to self-isolate with that child for the full period of time and have testing to mirror the child's. So I recommend those fact sheets to you, particularly that frequently asked questions one. We're finding that's come up a lot. And lastly, I thought I'd just touch on some of the diagnostic challenges. And so here's a scenario that I invite you to think about. And whilst we won't be using Slido to collect your answers, I invite you to determine what your response would be. So here is a person who is 42, male. He was potentially exposed to COVID in his workplace. So there were a couple of other COVID cases at this workplace. His particular risk we assessed carefully on a number of occasions. We thought it was low overall, and he remained stubbornly asymptomatic throughout this process. So there's some epi there, but no symptoms. And on an initial swab at a private lab, he had a detect, so this is a positive result. We talked a bit about these CT levels, cycle threshold levels last year. And so for formal PCR machines, this is a useful reflection on the amount of virus that's there. And when the amount of virus that's there is low and the machine needs to cycle many times to hit a signal threshold, then a high CT level or value reflects what's likely a low level of virus. And CT values in the mid 30s are getting up to a highish level. This person remained well, took themselves off to another private lab, different lab, 2 days later, got a result back that that they did not have COVID. It was a non-detect. Went the next day, it was a non-detect, and rang us up to say we had falsely isolated this person and he wanted to go back to work. So I invite you, we won't collect responses, but invite you to consider what your response would be in that situation. Wake up my phone. Now we were concerned. Clearly, it's actually go back for a moment. Clearly important to think about the possibility that that first result on the 25th was a false positive. And we've definitely seen these, that they're not uncommon. It's an important area to consider. And I guess the triggers for really thinking about false positivity are when the prior probability is low, when there's not a strong epi story, when someone doesn't have symptoms. So the fact that he was asymptomatic supports that. The fact that there were workplace exposures, we'd be really concerned about launching into an assumption of false positivity without looking very carefully indeed. And that was the trigger for us to test him one more time. The Belmont LEAT test, which is our drive-through express test. So that people, it's a formal PCR, but people stay in their cars, get the result before they drive away. We organised that, and that was a positive. And again, at modestly high levels, done on another platform. That's what the Oz Diagnostic, again, it's a platform. So here's a person who did in fact have COVID, and I guess we were also concerned by the time we got to this fourth swab, we'd heard that his son also had a weak positive result, and that the father was the likely source. I share this little scenario with you just as an example about some of the complexities that can arise. So really important to recognise that false positives are possible. Here's an example where, if you like, there were a couple of false negatives. So those tests on the 27th and 28th, which were non-detects, just simply didn't detect the fact that he, in fact, had COVID. So presumably at low levels of virus. We are carefully guided by the epi in addition to symptoms. So plenty of complexity there. If you do find yourself in the months and years ahead with some of these complex challenges, I guess we have accumulated extensive experience now, as have the ID clinicians who'll be happy to support us all. And then my last slide is just, we've talked about false positives, we've covered false negatives. There's some real challenges now with a highly vaccinated population, much milder illness in some people, high levels of asymptomatic infection. And young children are just extraordinary. And there's a number of experiences we've had now where young children have clearly cleared COVID virus very rapidly. And that's something we need to take carefully into consideration. I'll finish with just a brief message around rats. So lots of people talking about rapid antigen tests. Really important to distinguish that the express test that I just mentioned down at Belmont, for example, sometimes called a rapid process, but try not to use that word. At Belmont, the LEAT is a formal PCR. That's in quite a different category to these rapid antigen tests. And I think their place in our kind of collection of testing options is still yet to be really formally resolved. But important, I think, to think about rats as screening tests, definitely not diagnostic tests. their Achilles heel really is their modest sensitivity, and so the utility does very much depend on the pre-test probability. Somebody who's symptomatic in Newcastle or Moree at the moment, then a rat, if positive, is really likely to reflect underlying illness. The sensitivity varies by brand and test and those circumstances, so anything from 30% through to perhaps 70% at best. So there's probably going to be roles for rats, particularly in the same population with repeated tests, where you can compensate for lower sensitivity by testing over multiple times. For example, in the text you can see there on the right, 2 to 3 times a week. But there really is potential for false reassurance. We've seen that play out in the current outbreaks at the moment. And a rapid antigen test, a rat test, is not notifiable. It's not diagnostic. We don't hear about them, and it's not notifiable. I'm sure there'll be lots more on rats in time to come, but I'm going to stop there and look forward to questions and answers at the end. But at the moment, I'd like to hand you over to Miriam Grotowski and Marie Puxty. Thank you very much.
Thank you, Tony. That's great. So we'll just get Marie to share the slide, and thank you for inviting us to speak. So we're coming today to discuss our experience as GPs that work in the New England Northwest area. And as we've just heard, we sort of got together and became interested in having discussions as local clinicians when we realised that the case numbers were rising in Newcastle, and we could see that what was about to happen was that cases were also going to rise in our region, and we were particularly interested in a local response. What did it mean for our communities when we started to see cases with COVID? Because the response that worked in Newcastle City, for example, may not be applicable to Warrialda or Manila, or indeed even Tamworth and Armidale. So I'm chair of the New England Northwest Health Professionals, and I decided that it would be a really good idea to get together the GPs that were interested in discussing this and getting together interested other bodies. So I'll pass over to Marie to talk about what then evolved into a regular weekly meeting.
Sorry about that, everyone. There's a slight technical issue with the sharing of screens. So Marie, if you just like to stop sharing your screen, and we'll be able to go back to the PowerPoint in a moment. You'll see there in the chat, there's lots of questions coming in. Please keep sending them in. We have some time after the main presentations to go through all of these questions. So we definitely encourage you to enter them in. Won't be too much longer. We'll get back into Miriam and Marie's presentation.
Hi, everyone. Sorry about that. Obviously, I clicked on the wrong thing, which was utterly predictable. As Miriam said, we felt that we needed to sort of work together and bring as many general practice groups to work as a bit of a team. And I'm the chairperson of the New England Division of General Practice, and also the chairperson of the Primary Health Network Rural Clinical Council. So Miriam initiated this process, or Northwest Health Professional Network did, and then we kind of all joined together. And so we now have Northwest Health Professional Network, New England Division of General Practice. We then invited Hunter New England Local Health District, and expanded to include Barwon Health Alliance and Hunter New England Central Coast Primary Health Network as well. So basically we have people from primary care, the PHN, and tertiary care trying to work together to really work as a team to develop a clear shared care referral pathway for COVID positive patient management in the New England Northwest region. So local solutions for local issues for our patients. So our goals, firstly, our first goal was to remove the Hunter New England Local Health District Bed 25 admission rule. And basically, prior to that, it meant that general practitioners were unable to bill Medicare for any consultations that they undertook with COVID positive patients. So patients at that time were considered inpatients in hospital in the home, or what is now called community care in the home. And it meant that GPs couldn't bill Medicare. So we were able to negotiate with the local health district, and patients are now considered outpatients rather than hospital in the home or COVID care in the community inpatients, which means that we can bill Medicare if we are involved in the management of COVID positive patients. The next thing that we thought we really needed to work on was the fact that GPs haven't been being notified that their patients are positive. So again, we negotiated with the local health district, and now patients who have nominated a particular GP and are found to be positive, the GP will receive a doc fax in the same way that we do when any patient is admitted to hospital for the local health district. So that started last week, and hopefully people have been receiving those doc faxes. The other thing is that pathology providers, we did negotiate with them to try and take the name of the GP at the time of a PCR. Obviously, if we order the PCR, then we get notified. But if people go through drive-through clinics or community clinics for swabbing, then we don't get that result. So hence, we did negotiate with the pathology providers, but they were unwilling to change that. However, what they have done is on the SMS result that they receive, it's now suggested that they contact their GP at the time. So they receive a positive result and they're encouraged to contact their GP. The third thing that we're trying to do is develop a shared care pathway between primary care, outpatient COVID in the community care, and inpatient hospital care. So what we want is a clear referral pathway for escalation, who to contact and how for all the New England Northwest regions. So we really, no matter where you are in this region, we want you to know what you have to do if you need to escalate a patient. We also want a clear pathway to access and to be able to undertake sotrovimab infusions, which I know in Moree seem to be having an extremely positive effect and certainly seem to be keeping people out of hospital. We want a clear pathway, or we wanted to develop a clear pathway for access to resources such as PPE and pulse oximeters. We wanted a clear path to develop a clear pathway for phone and specialist support for escalation of medical and social needs, no matter where you are located in the New England Northwest. So, and then we wanted to develop a document on health pathways, emphasising local access and resources, and then communicate that health pathway and the recommended guidelines and the access numbers to New England Northwest GPs via the Hunter New England Central Coast PHN network, our GP network email systems, and tonight PHN webinars. So I'm now going to pass back to Miriam, and just to let you know that that process is happening, but it is still a work in progress.
Thanks, Marie. So we just wanted to just share some of our learning. So that's the work that's gone on and is still going on. But we noticed that we've had quite a few GPs from across the region sharing our meetings, as well as many representatives with thanks from Hunter New England Local Health District and the PHN, and particularly those working on pathways. And we really do appreciate their presence. We've had Tony Merritt join us from the Public Health Unit, and these short, sharp meetings work very well to get ideas nutted out, as well as some email flow that happens in between. We get presentations and updates from all the individuals, and then we have a question and answer time, which we have found very, very effective. It is interactive, it is efficient, but we still note, as Tony alluded to, that we have some vulnerable populations, and the tyranny of distance is an issue for us in our rural settings, transport being a problem for, say, accessing Sotrovimab, as well as the issue of access to social supports. But working as a local group with local solutions and local knowledge has meant that we've moved much faster in this space than we would have if we were all trying to do this as individual GPs on our own. Next slide. Thanks, Marie. Really, this is over to, none of this would have happened without the incredible background work that was already happening in your region. So we have Joe and Michelle and those from the PHN to thank for this, and they have subsequently developed this health pathways that you will be able to, and hopefully have already started to see and use as a useful tool for helping us to manage our patients with COVID in the community. And I had no further comments to make about this particular space. So I think we'll hand over to Joe and await questions during the question time. So thank you, Joe. And Joe knows that the time's been incredibly helpful.
Thanks, guys. Just realised, do I get to see my slides, or do they not come up? Okay. Thanks, Miriam and Marie. That was a fantastic presentation. And Tony, it's been very helpful. And these meetings, yeah, have been incredible at generating momentum. So very grateful for everyone's contribution. So I was working in the vaccination hub at Belmont, but I'm actually working with the COVID care in the community team now, which is why I'm presenting tonight. So I can give everyone just a quick overview of how things are going there. So this is for the care of the COVID positive adult in the community. So I'll chat quickly about who we're seeing in the COVID care in the community team now. I'll give you guys a bit of an overview of our model, including the risk stratification and the interventions that we're trying to implement for people when we come meet them, and discuss, actually Tony's really covered this quite well already, but the likelihood of hospitalisation in a population with a high vaccination rate, and also just the role that GPs are already playing in the care of COVID positive people now. Of course, I always start my presentations with a plug for Health Pathways. I'm hoping that everyone is aware of the username and password for them now. I've spoken to some GPs just in the last week who weren't familiar with Pathways, and it does take a little while to get your head around. So I can just do another plug, and really I think maybe the key message here is that communication to everybody, that it's there and it's written by GPs for GPs. So very much word of mouth, I think, is what's required to make sure it's out there and people are aware of it. Tony's already, again, given us this lovely overview, but just our current numbers. And this is actually from our data in the COVID care in the community team, prepared by Dr. Mark Lowenthal, who's our director. So it's a snapshot, about 2 days old, again, showing that distribution of age that Tony was talking about, how we've got, it's really the bulk of the people that are COVID positive are under 20. And we've got the R value sitting and hovering. We had a very anxious time there back in earlier in October, where the R value was well above 1, and it's now sort of hovering around that 1 mark, which is a tribute to the wonderful work that the public health team have been doing in containing the outbreaks. and the people that have been managing their isolation so well, I think, is probably tribute to them too. Again, this is a snapshot, and it's just showing the percentage of people that are unvaccinated currently in the service, and roughly half of them are unvaccinated. And again, half of the people that are in our service right now are Aboriginal and Torres Strait Islander, or Torres Strait Islander. I think this is helpful. These conversations that we've been having is, we know how we were planning when the outbreak was at the start, and a lot of our planning and the guidance that we have from the ACI is around a low vaccinated community, but we are seeing now that our vaccination rates are much, much higher. The outbreak is now settling across the state, if you look at it from this graph. And again, just to emphasise that now is a much better time to be having an outbreak than when our vaccination rates were lower, with significantly lower ICU and hospitalisations in the vaccinated population. And these slides, the graphs there on the right have been picked out just to show the difference in that 40 to 59-year-old age bracket, with the blue line being the fully vaccinated ones, not being in ICU and not being in hospital, and the red lines being the vaccinated ones, people that are in hospital and ICU. So our current COVID care in the community model, we have a person that tests positive. It is put onto a statewide patient flow portal, which we can see, and the information that public health teams are gathering. We don't get all of that information, but we certainly know that they've been interviewed by the public health teams, and we try and pick people up as quickly as we can. So it can be on this first day of that their result is tested positive, and that's not how it was about a month ago, where there was a delay in picking up people for initial assessments. But this staffing has surged, and we've got much better capacity of picking up people for their initial assessment, which is really a critical part, because at that point we're reviewing which risk protocol they should be on and whether they're going to be eligible for sotrovimab, which is critical for our rural people that are COVID positive. If we can reduce their risk of hospitalisation, then that's something we really want them to have access to. Then we do our monitoring, where we're assessing their disease severity at that point in time, and working out whether they need to be in hospital, really. And then toward the end of that period of time that we're monitoring people, we get to the day 14, and we work out, usually day 14, if they're meeting their de-isolation criteria, and we're de-isolating them. So that initial assessment, as I've really just sort of touched on that already, we're trying to work out how sick we think they could be if they did deteriorate, so their risk of developing severe disease. And then we will assign them a risk protocol. All right, is it going to let me do that? Sorry, this is just a snapshot from the health pathway that is going through the indications for sotrovimab. Sorry about that. I think I've got my animations in the wrong order. But really, it's a fairly broad list. So it's within 5 days of symptom onset. It's for people that are unvaccinated, or not fully vaccinated. So if they've had a single dose, and if they've got, risk of severe disease, which is diabetes, obesity greater than 30, chronic kidney disease, congestive heart failure, obstructive lung disease, moderate to severe asthma. So there's a broad range there. And we're also trying to capture Aboriginal people unvaccinated, older than 35. Sorry, the slides are not progressing. Here we go. So that was the this is the animation I was hoping to come up. There we go. So this is the ACI document. Links for all of these things are in the health pathway, so don't get too preoccupied with them. It's really just trying to stratify people according to social risk factors as well as medical risk factors. And then at that point in time, we often identify if people need some extra support with isolation. Often the public health team identifies people that are really going to struggle with isolation, and we have been using hotels to help those people if they're not going to be able to manage that at home. But there is a COVID-19 isolation support page that has been worked on by the team very quickly and has put a lot of effort and work into it. But I think this is a really good time to sort of remind everybody that the pathways is ours. So if we find local resources that we want to share with our colleagues, then that little blue button at that right down the bottom there of the corner is monitored all the time. And if you find something that you want in that pathway, then please put it in there, because it's definitely going to be helpful for somebody else. I sort of just wanted to pull down just to show you that you can get some local information. So I pulled out the Armidale one there. If someone was having difficulty with food or financial assistance, then there's some organisations that have already identified that they would be happy to help in those situations. So this is the daily assessments. I was just talking about that. How sick are they today? So we do we have a standardised template that we go through. Again, it's in the pathway if you'd like to use it or just have a read. Based very much on the ACI document again, and the yellow and red flags really is how they separate things out. But just which people, so it's a nurse-led service really that do the most of the assessments, and then they escalate to the doctors that are in the team, and then we will assess whether they're really got enough signs of moderate disease or severe disease, and whether they need to go to hospital. But of course, having those red flags of critical or severe illness very clearly mapped out, so that people know that they can call an ambulance straight away. And a large part of our counselling every day is around educating patients to understand the disease course and to know what triggers they would be looking for in terms of escalating their own care. And the de-isolation, I think, is something that we often, when we were thinking about how this could work in general practice, how this is that sticking point of how things could happen. But certainly for the doctors that are working in the COVID care and the community team, it's a very simple process, because we can use a patient flow portal to send a notification to the patients, provided they meet the criteria, which is for the bulk of people that they get to their day 14 of isolation, they have been fever-free for 72 hours and have had substantial improvement in their respiratory symptoms for those last 3 days. And for most people, particularly people that are vaccinated, their illness is short. So they have well and truly met those criteria by day 14. So bearing in mind how our model works now, we've had comments from Maria and Miriam already about how we're sharing care. So the outpatient model is really fantastic news, because it means any contact your patient has with you is completely billable. And really the types of contacts that patients have been having with their GPs has been, flick this up, yep, has been in providing their usual care. So if people have scripts outstanding, or they have mental health concerns, or they have, I don't know, sore teeth. Actually, everyone's got sore teeth. That's a good one that comes up. They can talk to their usual GP or dentist ideally, but they're not obviously going to be able to visit their dentist. Isolation support, I think, is critical, just that uncertainty. And, as much as we try and carefully counsel people, when you're stressed, you don't hear everything that you need to hear. And I think having hopefully the information, the pathway for GPs to feel confident to explain what's going on to people, will hopefully be helpful in your contacts with patients. Escalations is that really important point that Marie was emphasising. So that's another role that we play in the COVID care and the community team, is that a nurse identifies someone and they bring it over to us. But we have noticed on many occasions that patients have reached out to their own GPs and told them that they're feeling worse. And and they have sometimes been able to address the concerns that people have had. Often asthma is something that's exacerbated, and so it's about making sure their asthma management is optimised and doesn't always end up in hospital. So that's something that people have been reaching out to their usual GPs for. The non-COVID care that I was sort of alluding to, that's not related to their current condition. Had a few pregnancies that have popped up, that sort of thing. New pregnancies. And then, so we have review protocols based on someone's risk of severe disease and the frequency of how often we're calling them. We're not using the protocols dictated by the ACI exactly. There's an incredibly intensive review process that is, initially was not achievable, but actually is not necessary in a highly vaccinated population. So, but some people will benefit from more intensive monitoring as well. So we monitor the high risk and very high risk groups daily, pretty much. Yep, for both of those groups. But then the lower and medium risk groups get less frequent calls, depending on capacity, actually. So at the moment, we're calling them more frequently, but really this is that space that we're moving into with this higher vaccinated population where in the UK, for example, people self-manage their symptoms and self-initiate their escalations rather than having somebody monitor them. So the initial, I've just circled this one out again, just to emphasize again what Marie was saying, that if you have someone reach out to you after you've, because they've found out that they're COVID positive, the critical thing at the moment is just to have at the top of your mind, can I reduce this person's risk of hospitalisation, and being familiar with the criteria for citrovimab. There's it's easy once you do, say if you did identify someone in the pathway, there's a little drop down box with contacts for COVID care in the home. So what happens next is a good question, and I think I've kind of just sort of touched on that already. In that double vaccinated population, can they do self-monitoring? People have their own SATS monitors, and we have some protocols for them, perhaps. GP-led telehealth monitoring or reviews of patients initiating their own care. And what's that role for the COVID care in the community team, the LHD services? Is it about really shrinking it back and concentrating on those most at risk of hospitalisation, and even increasing the intensity of their reviews? So yeah, some unanswered questions, but a good space to be working into. Thanks, and I think we're over to our question and answer time now, Charles, is that right?
Thanks, everybody. Thanks, Jo. I will just briefly summarise some of the changes that have gone on since we last had a webinar, because it's actually quite a big change, isn't it? Last time we had a webinar, Mark Lowenthal was doing most of the talking about COVID care in the community and how, all of the patients were being managed under that model. And of course, as Miriam and Marie said, the Bed 25 change has been critical in allowing GPs now to be involved. And so these low risk patients now can reach out to us and we can do some telehealth with them. I think the waters have been slightly muddied, haven't they, by this face-to-face item number that's come up. And I just wanted to be really clear that we're not expecting GPs at this stage to be seeing COVID positive patients face-to-face. This is a telehealth driven model. So I just thought I'd just do that little summary. So we have got a few questions. I think this first question I've got from Dr. Ali, which is probably to you, Tony, if that's okay. Asking about management of an exposure site in a surgery. So we had 2 cases in our clinic over last week, but we were advised that it's still low risk and no need to contact other patients to alert them. I think this is a real worry for general practice, isn't it? Are we going to get closed down, have to pay for a deep clean contact all our patients, send all our staff home, all of these things? What's the process?
Well, look, I think you'll forgive me for going straight to prevention. And then have a go at answering that question, because of course it depends. But look, we've had so much experience now. For a start, before that, that the epi curve took off for us locally, we were flat out helping our colleagues in Western and Southwest Sydney, and they bore the brunt. And really, there was lots of learning through that period. We saw the whole model of delivering pharmacy care, for example, just changing to street side, and a lot learnt in the primary care practice setting at that time. So look, a real plug for the benefits of strict use or quality use of masks and eye protection. And time and time again, it's becoming less now, but time and time again, the element of PPE that has let healthcare practitioners down, either in the primary setting or in hospitals and elsewhere, has been lack of adequate eye protection. And that's a pathway to exposure. And it's so simple to address. So shields or proper goggles. So look, a real plug for staff, anybody in the practice who's coming into contact, as in, talking distance from people coming into the practice, really strict attention to those measures. And of course, everyone should be double vaccinated. And then practicing, the distance and time issues, really do make a difference. So clearly flow through your practice, you'll want people to be spaced, to not be waiting in the practice building a moment longer than they need to. So in terms of bookings and where you have people waiting, and keeping any consultations face to face, obviously screening people so that it's not people with symptoms or COVID risk factors are there in the room. Now, it's certainly, with all of those precautions in place, the impacts on a practice can be really very minimal in terms of needing to send people away and get tested. So attention to that kind of preventive measure is just absolutely paramount. But to answer the question, we've got a very experienced exposure assessment team here now, environmental health officers. We've surged that team. So if we learned tonight that there'd been an exposure, earlier in the day, an exposure in a general practice up in the New England area, and that team has reached out to the practice, spoken to a principal already this afternoon, shared the self-assessment kind of protocols. There's a matrix, of course, that takes into account the level of personal protective equipment, the amount of time somebody spent in an exposure setting, and the distance. And all of those things play into the implications for everybody who work through that process. So if you're keeping distant from people, if consultations are short, if you've got that high level personal protective equipment on properly, then the implications for practitioners can be extremely limited indeed. In terms of the specifics, I don't know, Dr. Ali, exactly those circumstances, but if it involved our team here in Hunter, New England, and there are questions, then I certainly invite you to get back in contact with us if it's not clear that that's been thoroughly assessed. As I say, we've really got superb expertise locally here and able to give both preventive advice, but around particular exposures. So I hope that's addressed that question with a plug for prevention. Thanks.
Thanks, Tony. So prevention all the way. That's the best thing, isn't it?
Yes.
Another question just on that sort of theme is that, do you see any movement coming in? Is there going to be a chance for us to reduce restrictions, bearing in mind we're in P2 respirators all day, face to face, which is extremely tiring, fatiguing, and difficult to keep a supply of respirators going, actually, in general practice.
Look, really challenging. We're on the receiving end of some of that kind of PPE requirement as well, of course, and we don't drive those changes. We're also recipients in terms of guidance. I don't have a crystal ball there in terms of what's coming. There's going to be progressively massive changes over the next 6 months, of course, in lots of areas. No, I'm not sure I can add anything useful there, I'm afraid.
All right, thank you for that. Okay. A few more questions. Can GPs directly contact CCITC if we're concerned about a patient? That's probably a question to Letitia, who's on the CCITC. I should introduce you.
Yeah, look, thanks, Michelle. Yeah, basically, yes, you can contact us. There is a number on the health pathways. Like, yet again, definitely look at health pathways. It's not something I've had much contact with GPs. We can also ring you. I think that was one of the questions that popped up there. Someone was asking, do we contact you for health summaries, etc. Again, it's something that's not being done routinely at the moment, but hopefully maybe with time we'll be able to open up more communication as well. Yeah.
Thank you. Yeah, so that's that one. Are your daily checks telehealth only? What about patients who have no smartphones? I'm assuming you're using phone, like landlines and, this sort of technology. Is that right, Letitia?
Yeah, so that has been challenging in certain populations for sure. So usually, yes, we're ringing patients on their mobiles or landlines or whatever number we can track them down on. Sometimes we spend a lot of our time just trying to get the right contact number. And recently, with certain populations that didn't have phones, we've had some people, thankfully, on the ground going and door knocking through various phone calls, various teams working in the backgrounds, working together. But most of the time, the contact is just by ringing on their mobiles or phones, which we usually get from the public health unit, the same number they've been contacted on.
And I guess as GPs, if we were sort of getting involved with managing our own patients, we might have those contact details. But I understand a lot of these patients don't have a regular GP. Is that something that you're seeing?
Yeah, that's definitely where, if someone's got a regular GP, it could be a lot more efficient if their GPs were willing to get involved in their care or able to get involved in their care, because they will have we spend a lot of time trying to get that basic background, trying to find out their social situation, etc. So that could be an area, if someone has their own GP that looks after them, knows them well, knows all their background, that could be really helpful if they can help out as well, if that's the model or the path that they go down. And then we can focus on those patients that don't have a GP, and then we can try and track them down, find out their past medical history and implement the services that we can put in there to help support them.
And Jo, you look like you have something to say.
I do. I have
and a friend.
My assistant here too. Apologies. So I just wanted to say that was a fantastic point about medical history. And if people have an opportunity to update their MyHR for patients, we can access that at the hospital, and it's actually a really great opportunity to save heaps of time, because as everybody knows, calling is never as straightforward as you would like it to be. Though that phone number, just to emphasise, is directly to one of us sitting at a computer, so it's a landline right there to us. The Citrivimab, I think there was some concern about would someone be picked up for a Citrivimab. So we're doing well with that, I think, at the moment, but that's for people that we can identify readily, and there's a potential that maybe some of the pre-demographic, so the demographic information that we've got may not capture everyone that's at risk. A lot of that risk is determined by their risk of hospitalisation, and if someone is really well managed by their GP, they may not have gone to hospital very many times, so we may not pick up that extra bit of risk as well. I see another question there about the pulse oximeters. So yes, everyone gets a pulse oximeter. Sometimes there's delay, and again, that's at access, like distance and making sure that happens. But that's happening better. So it's one of these things that's improving all the time. But certainly if you find somebody at home, they've reached out to you and they don't have a SATS monitor, then again, that's something that you can escalate to COVID care in the community, and we can try and help sort out for that patient. Hope that covers some of those questions.
I think John might have some, thanks, Jo. And I think John might have some information maybe about where that's heading. John, have you about pulse oximeters?
Yeah, I do.
In the future?
Thanks for that, Michelle. Yes, the plan is for the patients who will be stratified to general practice directly in the future. There will be access to pulse oximeters through the national stockpile. They'll be coordinated through the primary health network. And that's an emerging space at the moment.
And another sort of question on that, which is, I don't know, maybe Marie or Miriam might know the answer, but Sujata Allen saying she works in an Aboriginal health service in Armidale and has a patient who is struggling to manage using their pulse oximeter. Are there any services that can support those sorts of patients struggling with use?
I think the important thing is that we work together, and that's really what all of this background work has been about, to try and work as a team. So I think in answering Sujata's question, the health pathway has clear numbers, contact numbers to contact COVID care in the community. Yes, Joe, I'm saying good on you, health pathway. So it has very clear, particularly for Aboriginal and Torres Strait Islander people, there are some clear recommendations and contact numbers. There's an email address to try and access pulse oximeters. Hopefully they will eventually come from the PHN. And I think this is where, for example, Antigen could get involved. Aboriginal health workers can get involved. They are more likely to be able to have success, I think, communicating with the community. Certainly that's what's been happening in Moree. And I think this is where if Antigen reaches out to COVID care in the community and COVID care in the community reach out to Antigen and we all work together, then we can sort of improve this space substantially. So my suggestion is talk to one another.
Yes,
Thank you.
absolutely. I think that's
Okay, so thanks for that, Marie. That's an excellent answer. Simone Williamson asks, what percentage of cases are you seeing now that are fully vaccinated? With the case numbers consistent, I just wonder how the projections are being made now. It sounds like a lot of them are fully vaccinated in terms of cases, not hospitalizations, obviously. But
that's not the case.
Who's got the who's going? No, so that might be quite different in different. Yeah, so that's quite different in different areas. So maybe Marie and Miriam have got that experience in the Northwest of it being very much within the unvaccinated Aboriginal community. Is that right, Marie? And
correct. Yep. So my understanding is that in Moree and in Virel that the vast majority of people are unvaccinated, and something like 98%, I think, are Aboriginal. And the vaccination rates are sitting at less than 50%, plus a lot of them are children, obviously. So, yeah, I don't think you can presume vaccination in that community because there has been an awful lot of hesitancy.
And
may I
Tony,
say,
did you have some?
the communities have been, the Aboriginal community controlled organisations and GPs, everyone's been trying super hard to get people vaccinated. They're actually door knocking. It's just that there's been a lot of hesitancy.
Yes, I just echo that. I think just extraordinary efforts, as you say, door-to-door outreach, small teams. It's been really impressive, and it's hard work. I think there's been some incremental progress recently. Nothing like having COVID close to home to kind of make it a higher priority, but there's, as you say, real issues with hesitancy there that are slowly being progressed. Look, eventually, hopefully, we'll have very high-level vaccination coverage, and the vast majority of cases will be immunised. That's what we expect, of course. Eventually, if you had everyone immunised, the only people who were cases would be immunised. But it's a very, very patchy story at the moment, and it's over 80% of the people caught up in the outbreak in Moree, as you say, are fully unimmunised, and so it's a story of COVID seeking out vulnerable populations, and it's Aboriginal communities at the moment. It was other populations in Greater Newcastle a month ago, and it'll be different people again in 2 months' time. But with a reproductive rate of estimated in the order of 6 to 8, I mean that is extraordinarily infectious agent. And it's going to seek out under-immunised and vulnerable groups.
Thanks,
and
Tony.
big events, I guess. Yeah, sorry, I was just going to say in big events, because we know too where people are gathering, that's still the risk. So just, I guess, as GPs, our messages to our communities are really, really important too, and just keeping flying the flag for that protection, the benefits of the vaccination, but the benefits of social distancing and masks when we're in crowds. And, I think that's so very important.
Yes, thanks, Miriam. Yeah, definitely. I missed one from earlier, sorry, to Rod Martin, who asked how much does swab quality come into the result? That's based on the case that you presented, Tony. Any comments on
Yeah,
that? He's saying that see some pretty interesting sampling methods. I've
yes, I wonder whether
experienced some
it's a
fairly interesting sampling methods in my multiple
euphemism.
swabs.
Right. Yes, I think everyone's had their swabbing experience so far. Look, the labs are very quick to make this point, so it's a critical point that the pre-laboratory elements are very influential in terms of getting useful swabs. So, if you're sending someone for a swab, for a nose and throat swab, it really should be both nostrils and the throat. And if it's not that, if people are saying it was just gently waved around the front of one side of a nose, for example, then unless there's some very special reason for doing it. So sometimes we might knowingly trade off sensitivity in a circumstance where we just know we can't get a swab from a person who's, got real other challenges to address. But in the absence of those special circumstances, you really want that both sides of both nostrils and throat to maximize sensitivity. And if you're getting, we do get these reports, and we address them as best we can to both within kind of health service swabbing sites and privates, because it's really important that we maintain the quality, critical decisions being made for your patients, for the people we're dealing with as well. So yeah, it's a critical factor.
Thanks, Tony. And a question about billing for any of the GPs. How are we, if we're involved in these consultations, do we have to bulk bill those consultations? Are they subject to usual billing practices? What's the consensus?
I just saw a
ahead,
thing
Mary.
from Charlotte Hespy from the RACGP to say that we don't have to, sorry, that's my iPad ringing. We don't have to, it's my daughter calling me. We don't have to bulk bill if we do see someone face to face, which I think is, not really suggested except in extreme circumstances. We don't have to bill that $25, the gloriously large $25 fee. The telehealth remains the same as far as I'm aware.
Yeah, so telehealth isn't mandated bulk billing either anymore for some time, is it? So I guess each practice has to make its own decision about how they're going to bill.
Yeah.
Is that right? Is that what people are suggesting, Miriam?
Yeah.
Do you have any more to say? Yep, agreed. Okay, so there's no forced bulk billing on this one at this stage. Yeah, and the face-to-face one, as I said, I think that's a bit of a red herring, to be honest. Miriam, go ahead.
Oh, sorry, I was just going to add, I understand too that the college and other GP groups are negotiating at a Commonwealth level around the $25 fee, but it is recognised that there are some issues, and each practitioner will make their own call, but there is no compulsion to bulk bill.
Thank you. Thanks for that clarification. Another question would be about how to fit this work in around usual practice. Dealing with these patients who are COVID positive, that you get a notification. How are you going to arrange your time? Anybody want to comment on that? Because we're just sitting there twiddling our thumbs, aren't we, Marie? That was what you were saying.
Yeah.
I was just going to say, we discussed this at our practice meeting last night as a practice, considering how this looks. I think Tony made a very valid point, which is this pandemic is going to vary over time, and we will have times where there's more COVID around and times when there's less COVID around. And as we have more of a vaccinated population, I guess the acuity of the interventions will be less. So I guess each practice is going to come up with their own solution, and the solution may need to be agile, as we've demonstrated the ability to be agile throughout this pandemic thus far. So I don't think there is a hard and fast rule, and it might be a bit of trial and error. And what I would suggest is one of the things that our meetings do is get together and share the ideas. What has practice X learned and what's practice Y learned, and how do we share that information so that we're not all trying to reinvent the wheel ourselves? So I think it is an unfolding story.
And I think there's a difference, isn't there? I mean, I think at the beginning, when there was this story that maybe in general practice, we might have to be providing a daily review, as the ACI document suggested, as Joe alluded to earlier. And now what COVID care in the community teams are seeing with their lower risk patients is that they don't need huge amounts of monitoring. They certainly don't want to be phoned multiple times a day, one for each family member, which is the sort of thing that I was hearing. If you've got 4 family members with COVID and they're all getting a phone call every day, it becomes actually rather tiresome, apparently. So, so I think in general practice, it becomes more manageable, doesn't it? If you're just checking in with somebody who every few days by telehealth, that's something that, could potentially fit in with normal general practice, as long as you can program it a bit in advance rather than having to do it all on the hop. That does depend on telehealth rebates, though, remaining. I don't know if you know anything about that, John, going forward. Do we have any news beyond the end of the year?
We haven't had an answer. We've asked the question a number of times, and it still hasn't been answered.
Okay, thank you. Help me out here with any questions I might have missed. I'm just having a look.
I wondered,
So
Michelle.
There is a question from Eric Mack around what happens if a patient dies unexpectedly.
I was wondering about that one. Sorry, I did see that, Eric. Yeah. I wasn't quite sure what the context was. I guess there was, I thought it maybe could be taken in a couple of different ways. There's been deaths at home. I think that has, all of us have been worried about, what is it that we need to be doing that might prevent these deaths at home, and are they completely sudden? Is there some triggers that can get people in? And I think that we really need to have more information around those deaths at home. I don't think that's publicly available, so we don't really have a great idea. But certainly, it's going to happen in some instances, then we're going to be blindsided occasionally. But really, the sensitivity of the monitoring, if it's being done, is they seem to think that it's quite reliable with the checks, with the telehealth, that you can reliably predict if someone's going downhill. And I think that probably now that we've had this nearly 2 years of experience using telehealth, you can actually do quite reasonable assessments, even over a phone, even more so with a video consult. And really, when it's in this sort of triage-y kind of space where it's like, are you safe to stay at home or do you need to be in a hospital? There's really only 2 options. It's something that we can do quite comfortably. I think the ones where you're like, do I need to keep you at home and give you some antibiotics for a few days? A community-acquired pneumonia where you're actually trying to manage them out of the hospital. In this space, it's different. It's going to be oxygen therapy that they need. That's going to be in hospital. So it's just, have their SATs drop down low enough? Yep. Are they demonstrating some respiratory compromise? Yep. All right. Call an ambulance, off you go. And actually, that was one of the pre-prepared questions to say, the work that we're doing in COVID care in the community, is it within the scope of general practice? Letitia, would you say absolutely?
Definitely. Yeah, look, I think it's something, like you said, in the last 2 years, we've all learnt how to do telehealth, to either on the phone or video. And it's a skill that we probably all don't realise that we probably can do. And like you said, Joe, if they're escalating and getting worse, I think the great thing is to know that they need to go to hospital. And that's what you need to do if you're concerned or worried, or they're concerned and worried. And that's often at the end of our calls when we're talking to people, we often say to them, if you're concerned or worried in between our next call an ambulance, and get assessed. So we've got, I don't know, probably for our rural part, there might be a little bit more difficult, a bit more of a distance involved. But yeah, so that's, and The other thing that makes it a bit easier, I guess, is if the patients have their oxygen sats monitors. That can be a really helpful tool that we're probably not used to using up until now. With telehealth, is sort of letting them know that they can monitor that themselves, and if they've got concerns, they're noticing the numbers are dropping, etc., what they can do with that as well. But if also, the other thing I'd say as a quick plug is, if you can, I know not all patients can or want to do video telehealth, but if you can set that up, have your practice up and running for it, it does make it a lot easier. If even just showing that earlier question about how to use a pulse oximeter, again, and I know not all patients will have the technology, but talking them through, showing them, etc., on video, it can be really helpful. And yeah, if you're not already set up for video consults, maybe try and get that sorted before you get your first COVID case that you need to look after.
Yeah. Can I just
agree?
sort of
Great
chuck
plug
another thing
for
at
video? Yeah, go for it.
on the end of Letitia's thing, to say that I think the kind of care that we're doing is actually much better suited to a general practice setting, in that you plan an appointment, someone makes sure they're there. Like, we're doing a lot of sort of reactive, reaching out to people, and it would be really nice if we had appointments and people knew when they were coming in and someone had set them up for us, and all that stuff that we do really well in general practice, where it's very, I guess we have that admin heavy load right at the beginning of our contacts with patients, and then we step in. So I think that sort of stuff is something at the general practice, that's what we do, like that's how we do stuff. So we can plan for people, we can set aside, time aside in the day for our escalations. So that's, we can cope with those people that need to ring in if they need to. So I think, when we have some clarity about where general practice fits into the scheme of things and the numbers that we can actually expect, I'm feeling much more comfortable and optimistic about it being manageable.
And Joe, if we needed to escalate, we're not going to be sitting on hold like we are to the authority line, are we, for a prolonged period of time?
Look, no, I think so. It's always about numbers, isn't it? Like, so if we're having heaps and heaps of people, there might be lots of phone calls, so we might get, you might always get an engaged signal. But look, I think that's something that we can continually review, and certainly that's what's driven a lot of us to work in the COVID care in the community team, is understanding how challenging it can be in general practice. And it's just about having smooth lines of communication and referral points that are predictable, and you can rely on someone picking that up within 24 hours and not being lost for 2 weeks at a time, and all that stuff that you're just constantly chasing in general practice. It's hopefully definitely a focus for those of us that are working there to make sure it's working, because ultimately hopefully, like, this is all going to become just so much more manageable and normal in the future that it's not going to be a big deal at all. Fingers crossed.
Yeah. But as GPs, as you're saying, it's well within your skill set, and particularly with, telehealth, rather than just phone, being able to use that and knowing the patient, which makes it so much easier, doesn't it? So,
yeah.
Excellent. Thank you. Hopefully allayed a few fears there. So a couple of questions about vaccination. So talking about, is there a strategy to promote vaccination in casual or close contacts? And also the kind of slightly related question of how soon after recovery from COVID to vaccinate somebody. Because there's been a bit of confusion about that, because at one point people were thinking they had to wait 6 months, which is not the case. Is that right? That's to Tony, I think.
Oh, I'd love to do that. Yeah, so it's a fantastic message to make sure we're all super clear about. So really important for recovered cases to be vaccinated as soon as they're ready. And so we were saying at one stage the advice from ATAGI was you could wait sort of 3 to 6 months, and some of the public health order messages supported that. But these days, the kind of entry access you get by virtue of being double vaccinated, you only get 6 weeks grace with COVID infection for access to such things. Now, that's recognition of 2 things. Really important that everyone gets vaccinated. So if you've not been vaccinated, develop COVID, of course, you'll have some natural immunity. Great rock solid evidence that vaccine based immunity is more robust across the spectrum than recovered immunity. So that wouldn't be the case in some other conditions, of course, but so it's a really solid scientific base for saying vaccination's critical in this group. And there's no need to delay any longer than when people are kind of ready and made a recovery. So soon afterwards as is appropriate. I think that's the key message there. Is there a key strategy for casual and close contacts? Well, look, not that's driven specifically targeting that group out of the public health unit that I'm aware of, or out of New South Wales Health, but it makes good sense. We ask that question, of course, with everybody we talk to. It's critical for a lot of decision making. So there's an implicit kind of reminder to people as part of the process that it's critical. Michelle, did that kind of address that question?
Yes. I mean, I think if you're an unvaccinated close contact, then my current screening at the door would stop you getting into the surgery. On the
Good incentive.
for vaccination. It would be, no, you can't come in because you're a close contact and you're supposed to be in isolation and it's not urgent.
Yeah, and vaccine hubs wouldn't allow close contacts to come to, so that's entirely appropriate. Yep, see through the close contact phase and get vaccinated afterwards. So the strategy is around making sure it's a priority after that period of time. Absolutely.
And there's a slightly linked.
Michelle?
Sorry, yeah, Joe, go.
Oh, I was going to chuck in a slightly linked point about vaccination. We've just, and it's really only something that struck us in the last day or so. So with all these people that are getting Sotrovimab, we're going to test the system, see if we can reliably let GPs know that they've had that infusion. So we think that the DocFax system should work. We've got to double check that because people will have a 90-day period afterwards that they can't have the vaccination. It just won't work. So you've got to wait until that's passed before they can get their second dose or first dose, whatever they're up to in terms of vaccinations. So it's a brand newbie, and I think the practice nurses of our region to thank for that one because they picked it up. And we're like, good one. All right, we'll work on that.
Yeah, that's not on the consent form or in the screening questions at the moment,
No,
is it? Have you recovered from COVID? Did anyone give you an infusion whilst you were sick with COVID?
So it's all been escalated up to the ministry because I think it's one of those things because we had this really restricted supply. So when our outbreak was peaking initially, we didn't really even have Sotrovimab on our radar because it was just such a tiny supply. And now it's like, actually, this is I think it's called a highly recommendation from the evidence task force, and they've got a better supply. So it's just like, okay, now we've got it, but now we've got to actually make sure the systems are there to support it successfully.
My slightly related was not that. It was about people who come and they want to have a nice antibody test to see if they've had COVID so they can have an exemption. Can we just put that one to bed? Does Tony want to put that one to bed? Because it's an ongoing question.
Shortest, is it really? Oh, that's fascinating. Shortest possible time. Completely unacceptable. Yep.
Excellent. I love a hard no.
Yeah, no, look, we do serology, but it's really focused kind of purpose. Like if we're trying to work out just the epidemiology, has someone had COVID or not? How do we interpret some of those complex tests? For example, when we had our first proper COVID outbreak on a vessel off the coast here in Newcastle, it was really critical to understand which mariners had definitely been infected and so therefore couldn't become cases, to know that outbreak was over and we could move on. It might be the same in a complex aged care outbreak, but never to establish whether somebody has immunity. We just don't know the biological correlates from blood tests to immunity in any case. So there's applied epidemiological public health response reasons. I can't think of any for you never to get a pass on vaccination or to get entree into any way that I can think of. But Jo, were you about to jump in?
Oh, look, no, but I did. I just did want to talk to Sujata about the work that she's doing for Armigen and Armidale with their swabbing, and they're already in full PP and vaccinating. I reckon that we might need to get these guys in touch with Paddy Cashman, so just around these specific sort of scenarios to get that advice for those unique sort of situations, maybe.
Yeah,
and
I
Sujata,
know. I would just say.
Oh, sorry.
Oh, no. After
Oh
you,
no,
Joe.
I was just
Sorry.
going to say with the I think look, I'm sorry, I was busy and distracted before, but yes, absolutely, we need to improve our communication points with our rural AMSs, and I have details and been chatting to quite a few of your colleagues already, Sujata. So we'll get there.
And I was just going to add that Sujata's involved in, kind of a complex response where field swabbing is going to be critical. So when contact tracing is simple and nuclear and everyone has a mobile phone, then we get a list of close contacts with their mobile numbers. We send text to those people. They're responsible for going out and getting themselves tested on the appropriate regimen. If they can't, then there's field swabbing to support. Clearly, with a larger response, we've had big responses in Greater Newcastle, in Moree and Inverell, where field swabbing with people going door to door in a range of different settings is the only way to get appropriate kind of cross-section of swabs collected from contacts or potential contacts. So look, it's definitely complex, Sujata, and I don't know in detail all the work you're doing, but what I've heard, I understand just how critical that is. So, and that's outside that kind of simple off-the-shelf model. That's enough for me. Thanks, Michelle.
Thanks, that's great. And I think just really to finish off, because we are slightly over time, just coming back to the outbreak in Moree, Daikut's asking what's happening. Is it settling down or numbers increasing?
Well, look, just from the public health unit point of view, it's way too early to say. We've had a big number of cases again today, and it varies a lot day to day. But it's been a pretty steady time since a gentle start at the beginning of last week. So I'd say it's got a fair way to go. And when things do settle in Moree, we'll just wait and bide our time, and it'll be one of the other regional centres before too long with the same kind of dynamics playing out. So we expect that experience to replay a number of times until we get vaccination rates up high across the region. But Miriam, Marie, in terms of the local sense of how it's travelling?
I think what you were saying is exactly the experience. We're just expecting numbers to waver a little bit over the while. We're watching it percolate through the community, and the community itself is aware that, there are visitors. If it's in Moree, then it will get to Inverell. We know that. We know it will get to Tingha. We know it will get to Bogabilla and other communities, because the transport and pathways between those communities are very, very close. So I think we just sit and wait, knowing that it's happening in those communities, and looking to the responses. The GPs out in Moree have been particularly effective in upping their work rate and looking at helping patients access Sotrovimab. So, I think we just keep, as you say, keep doing a response depending on where the outbreak is at that time.
And I think Miriam's quite right. I think the numbers in Moree today are 112 this morning or something, and Inverell was up in the 60s, if I remember correctly. So that's escalated quite quickly, just because of the housing situation, the close contacts, and the lack of the poor vaccination rates, the vaccination hesitancy. It's spreading. It will continue to spread, obviously, but I think that I think they're doing a fantastic job in Moree, and I think that it's a credit to the local health district, a credit to the PHN, and a credit to the GPs that and the RFDS, that everybody has rallied so well, and it's been an example where teamwork has been very effective, and I think it's it could be so much worse.
Thanks, guys. That's really helpful to understand that kind of local context. Oh, so I have got one very last question, which is about Medicare rebates for if you're doing multiple phone calls to the same family. And as long as they're all medically required, I can't see that there's any issue. And of course, patients who are suffering from COVID are exempt from the 12-month, usual practitioner requirement as well. So, and unless anybody has anything else burning to say, I think we'll hand over to Charles. Anybody got anything burning? No, I'll hand over to Charles then. Thanks, everyone. That's been a great discussion.
Thank you so much, Michelle. I'd like to take this opportunity to say a really big thank you to all of our speakers and panelists tonight, Tony, Marie, Miriam, Joe, Michelle, Letitia, and John. We appreciate how busy you all are, and we know that you give your time generously in the evenings after working all day. So on behalf of the PHN, I just want to say thank you so much for spending your time with us. And of course, thank you to all of you for staying online with us and for entering your questions. That was a really great discussion. A couple of questions in the chat about whether the session is being recorded. Yep, it definitely is. And we'll get this uploaded in our education library on our website tomorrow. And a copy of the presenter slides will also be available. If you would like a certificate of attendance, please complete the evaluation survey that's now live in the polls tab in Slido. We really appreciate your feedback. We are always looking at ways that we can improve our education, and also we love to hear what topics you'd like us to cover in the future. So that evaluation survey will stay open now for the next couple of days. So if you don't do it before you log off tonight, please just use the same link and come back and fill that one out. We really would love your feedback. So thanks again. All right, that's all from me. We appreciate your time and we hope you have a lovely evening, and we'll catch you again soon at our next education session. Thanks very much. Good night.